Welcome back to the Compact Echo course. In this part of the course, we will talk about the parasternal short axis view. In the parasternal short axis view, we are located in the second to third intercostal space, besides the sternum, on the left side of the thorax, and compared to the parasternal long axis view, where the marker points towards the right shoulder, this time in the parasternal short axis views, the marker points towards the left shoulder. To get to the parasternal short axis view, you start in a parasternal long axis and rotate the transducer 90 degrees clockwise. So that orientation, as I mentioned, changes from the parasternal long axis, where the marker points towards the right shoulder, to the parasternal short axis, where the marker points towards the left shoulder. The patient is still in a strictly left lateral position to make scanning easier, and you scan as close to the sternum as possible. Otherwise, it's very likely that the lungs will block our field of view, and you might achieve other atypical views we will talk in this course about as well. As I've mentioned, it's mostly located in the second to third intercostal space. And one very good feature about this view is you can tilt the transducer from the aortic valve up until to the apex. So you can scan the entire cavity of the left ventricle. And how do you get this view? Well, here we start in a parasternal long axis view. This is the aortic valve, the mitral valve, left atrium, left ventricle, ascending aorta. And you keep the aortic valve in the center of the image and you rotate, and then when you always kept the aortic valve in the center, you achieve a parasternal short axis view of the aortic valve. Let's do that again. Keep the aortic valve in the center of the image and rotate, and you will end up with the aortic valve in a short axis. What is the anatomy we have to differentiate? Well, in the first views of the parasternal short axis, we focus on the aortic valve. The aortic valve has three cusps: the right coronary cusp, the left coronary cusp, and the non-coronary cusp. The orientation of the cusps is easy to remember, as the right coronary cusp always points towards the right ventricle of the patient, the left coronary cusp towards the left atrium, and the non-coronary cusp towards the interatrial septum seen over here. There are more structures you can differentiate. Mentioned already the right ventricle. This is the right atrium, the left atrium, the interatrial septum in between. The tricuspid valve, we will talk about it shortly, because the tricuspid valve is a very important structure in the parasternal short axis views, and the pulmonic valve, and here even parts of the pulmonic trunk. Let's have a look how this presents in a B-mode image. Here you can see the aortic valve in the center. Same holds true here. Not all the time you have this perfect image quality, but here you can differentiate quite nicely the right coronary cusp, the left coronary cusp, and the non-coronary cusp. The left atrium, the right ventricle, the right ventricular outflow tract, and this is the pulmonic valve, and this already the pulmonic trunk. Note that there is another structure we can differentiate. That's the left atrial appendage seen over here. So even in a parasternal short axis view, you can visualize the left atrial appendage. In this view, we have the same anatomical findings: the right coronary cusp, the left, and the non-coronary cusp. Here we already have a better visualization of the tricuspid valve, the pulmonic valve, and even more is seen of the pulmonic trunk. When the image quality is not optimal, you still very often are able to differentiate if you have a tricuspid aortic valve, here seen as well like this Mercedes star. This is the right, the left, and the A or non-coronary cusp. Here again the left atrium, the right atrium, the RVOT, and the left atrial appendage. The next view we are going to focus on is a focused view of the aortic valve. So we zoom in the aortic valve, the same thing we do in the parasternal long axis view. If you didn't see the video, if you want to know how this is done, just click the box in the video. Well, for this view, we see that the tricuspid valve has three cusps as well, we do see that it is a bit sclerotic or calcified, but there is no severe stenosis present, as you can see that the opening of the aortic valve is preserved. So always also focus on the aortic valve in the parasternal short axis view as well. The next view is a short axis view where we focus on the tricuspid valve. To achieve this view, move the transducer probably a little bit more lateral, so away from the sternum as well, and tilt in the transducer. Keep in mind that the lungs shouldn't block the field of view, and also keep in mind that this might be a bit of an oblique view. You can see here parts of the left ventricle, the mitral valve, this might be the left atrium, this is the right atrium, the interatrial septum, so we do not see always the aortic valve perfectly in this view, but we are focusing distinctly on the tricuspid valve seen over here. With the tricuspid valve, it's important that you can also differentiate the leaflets. In this case, we do see here definitely the septal leaflet, and this is the posterior or anterior leaflet depending on how you angulate the transducer. Here we do have the right ventricle, the right atrium, the pulmonic valve in this view we do not see. Just as a side note, down below here we do see the descending aorta. Another structure you can see, and you shouldn't mix up with a pathology, is the IVC, the inferior vena cava. Here with color Doppler information, you see that the structure is entering the right atrium. This is the interatrial septum, the tricuspid valve with trivial tricuspid regurgitation, the RVOT, and this is the IVC in the center, again, the aortic valve. Here are two more examples with a very prominent IVC seen over here, and here with color Doppler information again. As mentioned, all these views are important to display pathology, especially with the tricuspid valve. We can, of course, visualize tricuspid regurgitation or other pathologies of the valve. So in this case, you have a patient with amyloid heart disease. You can appreciate that the left ventricle is definitely thickened, and the tricuspid valve also looks a bit thickened. Furthermore, we can see with color Doppler information that there is probably moderate tricuspid regurgitation present, and in this view, with this alignment of color Doppler, you can also use continuous wave Doppler to estimate systolic pulmonary arterial pressures. So keep in mind the tricuspid valve has many views where you can visualize pathology such as tricuspid regurgitation. The next view we have to focus on is a distinct view of the pulmonic trunk and the pulmonic arteries. How is this done? Well, you can see it in this graphic over here that we always cut through several planes of the short axis view. For the pulmonic trunk and the pulmonic arteries, the marker of the transducer doesn't point towards the left shoulder, but more towards the head of the patient to really fit into the pulmonic trunk. Well, how is this done? In a scan, you can see here the anatomical findings in the B-mode image and the color Doppler findings in this view over here. So we can differentiate here the pulmonic valve, same as here, and this is the pulmonic trunk, and the pulmonic trunk divides into the right pulmonary artery and the left pulmonary artery. Sometimes when you have a large central pulmonary embolism, it's even possible to see the thrombus in this area, depending on where it is located. Additional information is provided by color Doppler. We do see a normal blood flow into the right and left pulmonary artery. We do see that there is a trivial pulmonic regurgitation, which actually is a normal finding. Furthermore, in this view, you can measure the pulmonic trunk or even the pulmonic arteries to see if they are dilated and if there is indirect information that pulmonic pressures might be elevated. The next view we are going to talk about is the view of the mitral valve in the parasternal short axis. How is this achieved? Well, we know the view of the aortic valve and we tilt the transducer downwards to the level of the mitral valve. What we can see here is a round left ventricle, and here would be the LVOT if we would tilt the transducer backwards to the aortic valve. And when we have the mitral valve in the center of our image, we can see the anterior and the posterior mitral valve leaflet with a nice opening. How does this look like in a B-mode image? Well, here we have it. This is a nicely normal round left ventricle with a good radial and circumferential left ventricular function. We have here the anterior and here the posterior leaflet of the mitral valve. This would be the RVOT and parts of the right atrium. So in this view, you can evaluate not only the mitral valve, but also the contractility in a radial and circumferential way of the left ventricle. In this next loop, we have a worse image quality, but still we can differentiate the left ventricle, the right ventricle, and the mitral valve and the opening of the mitral valve. So why is this important? Why do you need the views of the mitral valve and especially this parasternal short axis view? Well, this and many more other topics will follow in the next video. In the last video about the parasternal short axis view, we did have a look specifically on the aortic valve, how to get the parasternal short axis view in the first place. And we did evaluate the tricuspid and the pulmonic valve, as well as the pulmonic trunk and the pulmonary arteries. In the last video, we did stop in the evaluation of the mitral valve. And now we dig deeper into the topic of the mitral valve. Well, the mitral valve is very complicated. First of all, it has an anterior and a posterior leaflet. These are divided into three parts: A1, so the anterior leaflet part 1, A2, A3, and the posterior leaflet P3, P2, P1. As we can see in all these views, this is an apical long axis, an apical 2-chamber, an apical 4-chamber view. We can always see parts of the separate leaflets of the mitral valve, but in the parasternal short axis, you can see the entire mitral valve and all the leaflets with all the parts. So this is the posterior medial commissure, the anterolateral commissure, and here you can see you count it with A3, A2, A1, P3, P2, P1. So in the parasternal short axis view, you get an overview of the entire mitral valve, and you can probably see where, for example, mitral regurgitation is originating. Furthermore, you can measure in the parasternal short axis the opening of the mitral valve in case of mitral stenosis. How does it look like in a pathological example? Here we have a parasternal short axis view focused on the mitral valve again. This is the posterior medial and this is the anterolateral commissure, the anterior mitral valve leaflet and the posterior mitral valve leaflet. And you see that the left ventricle is thickened. Left ventricular function, at least from the radial perspective, is preserved. We do see parts of the right ventricle, the tricuspid valve as well. So now let's review our leaflets. So here we have the anterior, the posterior leaflet, anterior and posterior leaflet, A3 and P3, A2 and P2, and A1 and P1. Now we do see that the mitral valve looks a bit off probably, but we need to add color Doppler information. And with the help of color Doppler, we do see that there's truly a problem with the mitral valve. We do see mitral regurgitation. So this jet over here, there's turbulent flow, and this is the regurgitant jet you can already appreciate in this view. Well, most importantly, in this specific view, you see that the origin of the jet is in the P2 segment, most likely. So this is P2, this is A2. Here we have P3, P1, and here in the center of the valve, the regurgitation jet, which is eccentric, is present. The next view we have to talk about is the so-called papillary muscle view. Why is this important? Well, you can tilt, as I did explain in the previous video, from the aortic valve to the mitral valve until the apex to evaluate the left ventricle. And in this case, we have another view of the left ventricle with the posterior medial and the anterolateral papillary muscle. And we do see the cavity of the left ventricle. This is if you just initially you see parts of the mitral valve, and then we arrive at the level of the papillary muscle where you see this nice round left ventricle with normal left ventricular function. To repeat, this is the posterior medial and this is the anterolateral papillary muscle. Also focus on the pericardium over here. Sometimes you can see pericardial effusion. We are not done in the parasternal short axis. We have to continue with the apical view. So when you tilt even further from the papillary muscle view, you will arrive in the apical regions of the left ventricle. If you cannot do it by simply tilting, move one intercostal space downwards. So if you did stay in the third intercostal space, move to the fourth intercostal space, and with tilting, you will most likely reach the apical region then. How does it look like in a B-mode image? Here you can see the round left ventricle. We lose the papillary muscles and we arrive at the apical regions of the left ventricle. All those views, they are very important to see if left ventricular function is normal, preserved, or reduced, even severely reduced. You can evaluate in these views. Also, you can see wall motion abnormalities in case of, for example, coronary artery disease or myocardial infarction. Furthermore, again, note this bright hypoechoic line, that's the pericardium. In this case, we have normal, radial, and circumferential left ventricular function and a normal left ventricle. So now let's have a look at all the different cut planes we can have with the parasternal short axis. We start at the level of the aortic valve, seen over here. That's the aortic valve. Then we continue with the level of the mitral valve, seen here. So this is the level of the aortic valve, the level of the mitral valve. Here you see the aortic valve, here the mitral valve level. The level of the papillary muscles, here you can see an example where the papillary muscles are thickened and left ventricular myocardium is also thickened. And we continue even to the apical regions. Here you can see an example where this is a very important view. You see some hypertrabeculations in the apical region. This is a rare cardiomyopathy. In this view, you can already get a glimpse that the apical region have extended trabeculation, so this spongy appearance. To summarize, what are the views and how you have to tilt and turn and rotate the transducer? Well, we start with the parasternal short axis view. With the parasternal short axis view at the aortic valve, where we have the aortic valve in the center, where we see the right coronary cusp, the left coronary cusp, and the non-coronary cusp. We continue to evaluate the pulmonic trunk and the tricuspid valve, if we also want to include that view. Here we see the pulmonic trunk, the RVOT and the pulmonic valve, the right and the left pulmonary artery. We furthermore tilt the transducer down to the level of the mitral valve with the anterior and the posterior mitral valve leaflet, the P3, P2, P1, A3, A2, and the one segments of the mitral valve. And continuing from this view, we can tilt the transducer even downwards to see the papillary muscle, the posterior medial, and the anterolateral, as well as the interventricular septum is here as well. And here still parts of the right ventricle. And to even tilt further down, we do see the LV apex. Why do we need so many views? Well, in this case, in the parasternal short axis view, the whole left ventricle is displayed. You start at the basis and you can scan until the apex. So you can see radial, but also circumferential function of the left ventricle. Furthermore, you can evaluate global function and wall motion abnormalities. Is it preserved? Are there akinetic or hypokinetic areas? You can see if the ventricle is hypertrophied or the left ventricular walls are thickened. You can also get a glimpse at the right ventricle and function and morphology of the right ventricle as well. You can see the dimensions both of the left and the right ventricle. You can also see if there is right ventricular volume or pressure overload with signs of the left ventricle, the so-called D sign. You will see that in another video I'm going to present to you. And you can see all the valves basically. You can see the aortic valve in the beginning, the pulmonic valve, the tricuspid valve, and the mitral valve. With the mitral valve, you can do the planimetry to quantify mitral stenosis, but you can also evaluate where the origin or the possible origin of mitral regurgitation is located if there is a defect of the mitral valve. And of course, in the apical regions, you can detect even a thrombus, or as I have shown you an example of a non-compaction cardiomyopathy, where thrombus formation is also very important. This concludes the second part of the chapter of the normal anatomy of the parasternal short axis view. But we are not done yet with the parasternal short axis. We do have pathologies to discuss. In this part, we will discuss pathologies of the parasternal short axis view seen with B-mode imaging and color Doppler. If you didn't see so far the normal anatomical findings of the parasternal short axis, and if you want to repeat, you can always click the box and go back to the other videos. Starting with an M-mode evaluation of the aortic valve, we can use the M-mode to create the so-called aortic box. What is the aortic box? What is the M-mode? The M-mode is this line over time. So we only see this area we are scanning, and here we have the aortic valve, the aorta in the center. This is the left atrium, this is the right ventricle. And if you look closely, here we do see the aortic valve. We do see here it is closed and here it opens, and that's the so-called aortic box. You do see some fibrillation, so to call, with the aortic valve, which is absolutely normal, but this is how it opens and then it closes again. So this is systole and then it's diastole. So the aortic box is something you can use to see if the aortic valve is properly opening. The aortic box in a normal view with less good image quality seen over here, you still can differentiate that there is the box. You do see here it's closed. So here are several boxes with a normal opening of the aortic valve. And in this example, you do see a pathological finding. The opening in the first place is definitely reduced, so it doesn't open as good as the example on the left side, but it's also closing relatively quickly. So that's a premature closure of the aortic valve. And you do see that in the B-mode image as well. That points towards a reduced left ventricular function. You see this over time happening basically all the time. So the opening is reduced and the closure of the aortic valve is premature. Here you do not see that the leaflets are thickened, so this is not the aortic stenosis. You can see this in the B-mode image as well. So do not mix it up. We will take a look at aortic stenosis with M-mode soon. In this case, we have amyloid heart disease. You did see the patient priorly with the tricuspid regurgitation in the prior videos. And you have now the aortic valve in the center of the image, and you do see that the cusps are thickened. So we have here the right coronary cusp, the left coronary cusp, and the non-coronary cusp. The leaflets are thickened, and when we add color Doppler, we can see that there is aortic regurgitation present. It's a small regurgitation, it's a central AR, but still it is present, and with the help of color Doppler we can localize and to a certain degree already quantify. So if it would fill up the entire LVOT, it would be more likely severe. In this case though, it's a rather small flare seen in the middle at the center of the aortic valve. Moving on to tricuspid regurgitation, we can have the focused view on the tricuspid valve again. So this is the tricuspid valve, and here we do see a more moderate to severe tricuspid regurgitation. Keep in mind, this is still not the optimal view. We do not see the origin, so probably it is severe, but we need another view to actually quantify TR. I want you to focus in this patient on another finding. So we go back to the view focused on the aortic valve. This is the tricuspid valve, the pulmonic valve. The RVOT, we do see that the atria are dilated, but focus here on the left atrial appendage. So that's the left atrium, that's the left atrial appendage, and it is rather prominent. So in this case, if there would be a large thrombus present, you could even see it in a parasternal approach. Keep in mind that still for excluding a thrombus, you need a TE study, of course, but you get the idea that with a prominent left atrial appendage, you can also perform measurements and a visual assessment if there is a thrombus present and seen already in a transthoracic approach. And already you can see if a thrombus is present from TTE. More to focus on the left atrial appendage, so this is a specifically focused view where you can see bigger parts of the left atrial appendage, and you can use color Doppler where you see that blood flow is until the end where we can visualize. So in this case, there's probably no large thrombus present in the left atrial appendage. Simply keep that in mind if the left atrial appendage pops up, that you think about it and that you already can quantify it to a certain extent. Now focusing on the pulmonary artery, in this case we do not have optimal image quality, but we do see that this is the pulmonic valve, that's the pulmonic trunk, the right and the left pulmonic artery, where we do see here parts of the aorta. So this already is the ascending aorta. And with this specific view, we can perform certain measurements. We can, for example, measure the pulmonic trunk and the RVOT over here. In this case, it is definitely dilated. And we can use a pulsed wave Doppler to quantify the pulmonary acceleration time. So this time frame you can measure here, and if it is below 60 milliseconds, it's definitely pathological and pointing towards elevated pulmonic pressures. And in this case, yes, the size does matter. If you have an enlarged pulmonic trunk, do not forget to mention it in your report. Moving on to the mitral valve, we have the anterolateral and posteromedial commissure. So that's posteromedial commissure, that's the anterolateral commissure, and we can see all the segments of the mitral valve. And in this case, we do see something is wrong over here. So this is a MitraClip. You have an echogenic structure in the area of A2 and P2. So this is most likely a MitraClip. You see that the opening of the mitral valve is reduced, but as you can see in the next loop, also MR is definitely not severe anymore. You see a rest of mitral regurgitation over here, but this patient was clipped because of a severe mitral regurgitation. Furthermore, when you perform a MitraClip procedure, of course, you have to pass the interatrial septum, and you do see that here is a small iatrogenic ASD, so an atrial septal defect. You can scan that in a parasternal short axis or in a parasternal short axis from a subcostal approach, which we will discuss in the lectures of the subcostal views. Here I have an M-mode placed again with color M-mode, so this is the small iatrogenic atrial septal defect. Furthermore, when we have a MitraClip and the problem of the mitral valve, we can evaluate it in the parasternal short axis, but also in the parasternal long axis view, where you do see the reduced opening of the mitral valve in this focused view. Furthermore, in this view, we do see a normal contraction of the inferior and lateral parts of the ventricle, but look at the septal parts. This is hypoechoic, it's thin, that's a scar. So this is a patient with coronary artery disease after a myocardial infarction, where you see scarred tissue, where there is no thickening and no function present. In this example, we have a parasternal view of the mitral valve again. We have the anterior and the posterior mitral valve leaflet, and in the B-mode image, we already see that there is a problem with the P2 segment of the mitral valve. So in these views, you also can differentiate if there is a prolapse of the mitral valve or even a flail leaflet present. We can see with the color Doppler information that there's probably eccentric mitral regurgitation, which is definitely not trivial. So in this case, we have to see the mitral valve from several views to actually quantify mitral regurgitation, but we already know from the parasternal approach that there is a structural problem of the mitral valve already seen. Moving on to the papillary muscles, this is a loop we have seen in the prior videos, where we see a thickened myocardium and thickened papillary muscles. So for LVH, this view can also be used to measure the extent of the interventricular septum and the posterior lateral wall. Furthermore, we do see the right ventricle, the tricuspid valve, and here even parts of the liver. Always keep in mind that this hyperechogenic line is the pericardium, so pericardial effusion, if it surrounds the left ventricle, can very nicely be seen in this view as well. Here's an example of a non-compaction cardiomyopathy, a very rare cardiomyopathy. This is the level of the mitral valve, where you already see that the left ventricle is probably enlarged and that there is reduced function present. If we move the transducer, tilt the transducer to the level of the papillary muscles, we see the same. The ventricle is relatively thin and function is definitely reduced. But if we move towards the apex, we do see, or we start seeing, hypertrabeculation. So in this case, you can measure the trabeculated area, so the non-compacted myocardium, versus the compacted myocardium to visualize if there is truly non-compaction cardiomyopathy present. And you also can differentiate if there are 4 or more prominent trabecula present, which would be another hint towards the diagnosis of non-compaction cardiomyopathy. If you want to see a case of NCCMP, click the box in the video. One more important tip I can give you is that if you want to really truly see the most apical region, so the supraapical cap, you have to tilt the transducer even more downwards to see, in this case of non-compaction cardiomyopathy, even more trabeculations and larger areas of non-compacted versus compacted myocardium here as well, mostly in the inferior, inferolateral and lateral region of the left ventricle. If that's the case, you simply move one intercostal space downwards, so more caudally, and then tilt the transducer up and down, and very often you get even a better glimpse of the supraapical cap. Furthermore, you can use color Doppler. You have to reduce the PRF to approximately 30 centimeters per second, and then you can even visualize the trabeculations and the blood flow in the trabeculations way better, and this again points towards non-compaction cardiomyopathy. Optimally, in this case, you use contrast imaging, but contrast will be the topic of another lecture. Now, this already concludes the first part of pathological findings in the parasternal short axis view. We did discuss the opening of the aortic valve, we did discuss non-compaction cardiomyopathy and left ventricular function. We have seen regurgitations, mitral regurgitation, aortic regurgitation. In the next videos, we will focus even more on M-Mode measurements and on aortic stenosis by means of scanning it in the parasternal short axis view, and we will continue with pulsed wave and continuous wave measurements. Continuing with the compact echo course, we will discuss the parasternal short and also to a certain degree the parasternal long axis view, how to use Doppler, for example pulsed wave or continuous wave Doppler, and certain M-Mode measurements we already started to talk about in the prior video. So talking about Doppler, for Doppler we have to have an optimally aligned signal. So we have to have an optimal image, because if the image is out of plane or the image quality is reduced, Doppler signals won't be optimal, and that can influence, of course, the measurements. As mentioned, we will talk about the pulsed wave, the PW Doppler, and the continuous wave Doppler, the CW Doppler. With pulsed wave Doppler, you have a sample volume, so you measure in a certain area the velocities, and normally you measure lower velocities. With the continuous wave Doppler, you measure the velocities all over a certain line, where you can measure higher velocities and you do not have a distinct sample volume. The same holds true for M-Mode measurements. In M-Mode measurements, the image quality has to be very good because you measure a certain line over time. So also the M-Mode has to be aligned optimally. You have a very high temporal resolution, but you do only scan one specific anatomical area, which is also the limitation of M-Mode measurements. For you to make it easier probably is the anatomical M-Modes. This is a version of the M-Mode where you can align the M-Modes not from the transducer beam, but from different positions in the image. M-Mode might be an old measurement, but in some pathologies it is still useful and gives you a lot of additional information. Well, we start again with the parasternal short axis with the level of the aortic valve. We remember we have the aortic valve in the center of the image, here the tricuspid, here the pulmonic valve. And when we focus on the aortic valve, we have seen this patient already in the previous video. We do see that this is the aortic valve in the center with this thickened cusps. And here we have this central and mild aortic regurgitation. When we use M-Mode, we see that this resembles the opening and the closing of the aortic valve. This is the M-Mode and the so-called aortic box. So this is diastole and this is systole. We do see that there is a certain degree of premature closure of the aortic valve and it doesn't open entirely. But we do see if we add color information to this, here is the opening of the aortic valve and this is the closure. So this is diastole, this is aortic regurgitation. It is holodiastolic, so it's throughout the entire diastole, but it's definitely not severe as it is just this small line seen in this color M-Mode example. Furthermore, when we focus on the aortic valve, we do see very often sclerosis or calcifications. They can range from mild to really severely calcified valves. Also in this case, M-Mode can be to a certain degree useful. If you use M-Mode through the aortic valve again, seen over here, you do see that there is an opening still present, but the cusps, they are thickened. But the aortic box is preserved, so we do see this cannot be severe aortic stenosis. These are examples of severe aortic stenosis. You see that it looks entirely different. It's very hard to differentiate the diastolic part from the systolic part, and here you see the severely reduced opening of the cusps of the aortic valve. So the aortic box is very small. Also, you can add color M-Mode, color Doppler information. This is a small pulmonic regurgitation. So this is the RV, the RVOT. This is the left atrium. And here we have turbulent flow. Also here turbulent flow showing aortic stenosis. Of course, you cannot quantify aortic stenosis, but it will give you already information of what's ahead of you if you perform certain measurements. This is another example where you have a severely reduced opening and a regurgitation as well. Moving on to the tricuspid valve, we already mentioned that you can use color Doppler to display the tricuspid valve and tricuspid regurgitation, as in this case. You can use continuous wave Doppler. This is a different example, a different patient. Now, this is by far not an optimal signal. There is just trivial tricuspid regurgitation present, but we do see that the velocity never reaches 2.5 meters per second. But this is a huge pitfall. Always aim for an optimal signal, as for example in this case. Here we have the tricuspid regurgitation of a patient with amyloidosis. You do see it's definitely not just trivial, but here we have a really nice jet and a nice alignment of the continuous wave Doppler. And we do see that here the signal ends just around 3 meters, 3.1 meters per second. So this is resembling pulmonary hypertension. So a continuous wave Doppler signal above 2.8 meters per second. The same you can do in the parasternal long axis view, where you can see the tricuspid regurgitation here in an atypical view of the parasternal long axis. If you do not know how to perform these atypical views, click the box and watch the video on the atypical views of the parasternal long axis. Also here, if you look at the alignment of the color Doppler jet with the probably moderate tricuspid regurgitation, you do see that here we get a very nice signal, again reaching almost or approximately 3 meters per second. This is another example of measuring tricuspid regurgitation, also reaching approximately 3 meters, but you see that there is a problem with the tricuspid valve overall. This patient received a tricuspid clipping. So the tricuspid valve was clipped due to a massive or a torrential tricuspid regurgitation. Now we still see a regurgitation, but it's definitely not massive, or at least it's not torrential. So there's a reduction in the grade of tricuspid regurgitation because of this clipping of the tricuspid valve. A very important pitfall is that the jet has to be aligned optimally to perform continuous wave Doppler measurements. In this case, you see that's the tricuspid valve and the jet is a little bit eccentric. So with the continuous wave Doppler in this alignment, which would be seen like this, you can never measure the true peak velocity because you are not aligned properly. And this is also resembled in this signals, this is definitely not a good signal for the tricuspid valve. So in these cases, we have to try other views. We have to rotate the transducer, tilt the transducer, turn the transducer, probably have to go to parasternal long axis or apical views. Optimally, you can measure tricuspid regurgitation, of course, in the apical views to get an optimal signal. Just keep it in mind, wherever you measure tricuspid regurgitation, that the signal quality has to be optimal. This is an example where you see tricuspid regurgitation over here. It's also a little bit of an eccentric jet, but because the alignment is optimal, we can measure here the tricuspid peak velocity is above 4 meters per second. So this is definitely a signal which resembles pulmonary hypertension. So if there is optimal alignment, you can even measure eccentric jets. In this video, we will focus first on the pulmonic valve and the pulmonic trunk. Now we need this specific view. You have seen this view in the previous videos. If you do not remember, simply click the box up there. So what do we do with this view of the pulmonic valve and the pulmonic trunk and the RVOT? Well, we can measure, for example, the pulmonary acceleration time. The pulmonary acceleration time is this time interval over here. You see, this is where right ventricular systole starts, and until you reach the peak, a certain time interval passes. And that's the pulmonary acceleration time. And depending on age, the normal value is above 100 to 120 milliseconds. So this would be a normal example of a pulmonary acceleration time. If the Doppler signal is optimally aligned, you can also perform optimal measurements. Sometimes it's not that clear, so you have to perform several measurements or just save several beats to measure it just several times. In this case, again, you see a normal pulmonary acceleration time. On the other hand, you see here a reduced pulmonary acceleration time. Here it is in between 80 to 100 milliseconds, so approximately 86, 88, so I would say 87 just lies in the middle here. So when you have this kind of measurement, it's definitely reduced. What does this tell you? This gives you the information that pulmonary hypertension can be present. If it is more reduced, so below 80 milliseconds, it's definitely reduced. We see here 66 milliseconds, and here it is below 60 milliseconds and is severely reduced. So the lower, the shorter the pulmonary acceleration time is, the more likely it is that actually pulmonary hypertension is present. You cannot differentiate the grading, so you cannot say it is for sure severe pulmonary hypertension, but you can say that it is more likely present the shorter the pulmonary acceleration time actually gets. Furthermore, you cannot differentiate in a primary or secondary pulmonary hypertension, but you can again get the information that this might be the problem of the patient. You can do the same in a parasternal long axis approach. This is an atypical view of the parasternal long axis where we do have a certain degree of pulmonary regurgitation. I would say it's mild to moderate, and you can measure the pulmonary acceleration time here as well. And you see 3 measurements, all 3 are a little bit different. Overall, you see that pulmonary acceleration time in this case is mildly reduced. So it's definitely severely reduced, and this we can display with several measurements because it's not always that easy and it's not always as clear where to measure. Another measurement we can perform is when we grade pulmonic regurgitation. So with pulmonary regurgitation, we can measure the pressure half time. It's the same with the aortic regurgitation. You measure the downslope, so the downfall of the curve, and if this measurement is below 100 milliseconds, it's severe regurgitation. In this case, it's approximately 300 milliseconds, so that's definitely not a severe pulmonic regurgitation, but we can also see that already in the color Doppler image. Again, here's the limitation that this signal is sometimes very hard to get, and very often it's not as easy as you might want it to perform it. So If you have a truly relevant regurgitation, then it's definitely important to perform this measurement, but again, then it will be way easier compared to simply mild regurgitations. Continuing with the mitral valve, we have to remember the next view is the view of the mitral valve, the anterior and the posterior mitral valve leaflet. And we do see a color M-Mode study of mitral regurgitation. This is also a case we already have seen before, where we did say that this problem is around the P2 segment, so the posterior mitral valve, the middle segment, where we have MR, and with color M-Mode imaging you can see the opening of the mitral valve, and here would be the closed mitral valve, but here we have turbulent flow resembling mitral regurgitation. We can also use the parasternal long axis view and M-Mode to display the mitral valve. So here you see the mitral valve, this is the aortic valve to a certain degree, this is the tricuspid valve already, the interventricular septum, the right ventricle, the left ventricle, the left atrium, this is the pericardium, and this can be seen also in this M-Mode study. You see here the pericardium, this is the interventricular septum, this is the right ventricle, so you also see the tricuspid valve moving, but we can focus here on the mitral valve, and this is definitely a pathological movement. We can display this already in the B-mode image, where we do see a reduction in the opening of the mitral valve, but not due to stenosis, so it's not mitral stenosis we are seeing, but it's probably severely reduced left ventricular function. And we again have this premature closure of the valve. We do see it over here and in the M-Mode measurement. Another measurement you can perform in M-Mode are the left ventricular dimensions. You see here the M-Mode measurement, but be aware, as soon as we have reduced image quality, or in this case the lung is blocking our field of view, we cannot see anything of the heart, even though we have an image in B-mode, so we can differentiate the heart still in B-mode imaging, but we do see here the systole of the left ventricle and diastole of the left ventricle. We do see that the interventricular septum is probably thickened, as well as the inferolateral wall. For M-mode, as in many views or measurements in echocardiography or in ultrasound overall, image quality is simply the key. So if you have optimal image quality, your images will be very good. If you have a reduction in image quality or artifacts, or the lung just shadowing your field of view, you will have a reduction in image quality and also a reduction in quality in your measurements. So always be aware of that and try to focus on the optimal B-mode image. Overall, you can perform several M-mode studies. This is a post-processing of anatomical M-mode. You can see the aorta, so the aortic valve measured in the middle with the aortic box. And this is the left atrium. Here you have the right ventricle to a certain degree. This is the measurement of the mitral valve, the cavity of the left ventricle, the interventricular septum, posterolateral wall, and the pericardium. And this is a measurement at the mid-level, at the parasternal short axis of the left ventricle, where we do see the posterolateral wall, here the septum, and of course here less of the right ventricle. Overall, I never mentioned Teichholz or fractional shortening. While the Teichholz formula and fractional shortening are ways you can measure the left ventricular function, so left ventricular ejection fraction by Teichholz. This overall is not recommended by the guidelines, and we do not perform it in our Echo Lab, as M-mode holds several limitations and it does have several pitfalls. First of all, you need an optimal alignment. So if your M-mode is not optimally aligned, you will not be able to get the segments you want, and you will have wrong measurements. You only measure two segments, so normally part of the septum and the part of the inferolateral wall. And I cannot mention it enough, you need optimal image quality. But M-mode still can give you additional information, even though it's not mentioned in the guidelines. And especially for the evaluation of the valves, I sometimes like to use it, and especially color M-mode images give a very nice feeling of what the regurgitation or the stenosis actually looks like. And it also simply gives a better understanding of what's actually going on. Now, this already concludes the part of the parasternal short axis views. Soon we will continue with the apical, the subcostal, and the suprasternal views. So stay tuned.